Hello, everyone, and welcome to our broadcast today. I'm going to be your host, Julie McComish. I'm a Senior Digital Strategy Manager for the Digital Innovation Group at Providence. As a reminder, the information provided today during this event is for information purposes only. For any medical questions, please reach out to your primary care or healthcare professional. Now let's jump in. Joining me during this live event today is going to be Dr. Arpan Wagray, our Chief Medical Officer of Behavioral Medicine, at Providence, and Roger Dowdy, the Vice President of Mental Health Strategy at Providence. Just to kick us off, can both of you tell us a little bit more about what your roles mean and give us a little bit more context of where you sit in the organization?
Sure, Julie. Thank you so much for having us. And today is National Physician Suicide Awareness Day, so a very, an opportunity, an important place for us to start talking about something that's really a big problem. So I'm a geriatric psychiatrist by training, and as you mentioned, I serve as the Chief Medical Officer for Behavioral Medicine at Providence, and in a dyad partnership with Roger, and we oversee care standardization for behavioral health across our large footprint. And so really privileged to be a part of this conversation today. Thank you.
Thanks, Arpan. Roger?
Hi, good afternoon, and thank you for having us. So I'm a clinical social worker by background, with experience in crisis intervention, suicide prevention, and working with individuals who have mental health as well as substance use, misuse concerns. And I serve as the Vice President for Mental Health Strategy at Providence within the Population Health Division. And as Arpan said, we together lead the mental health strategy at the system level in partnership with our regional mental health and population health leaders.
Wow, it sounds like you guys have a lot on your plate, so very grateful that you're willing to spend the half hour talking with us. I know that it's National Suicide Prevention Month, and this is a really critical topic. Suicide is impacting a lot of people. I know personally, I've had more friends, coworkers, talking to me about concerns around suicidal thinking. And, this is something that we had been tracking even before the pandemic. We saw that suicide rates had been on the rise, but I imagine the pandemic must have had a pretty big impact here. Can you talk about how the pandemic is impacting people's suicidal thinking or the struggles that people are having?
Yeah, I can start and would love Roger to chime in as well. It's been interesting. So we know that the social isolation, economic dislocation, and everything else that was caused by the pandemic did have quite a significant impact on the mental health of most people. We've seen through great studies, through Kaiser Family Foundation and others, that the prevalence of mental illness, depression, and anxiety has increased substantially through the pandemic. We've seen that deaths by drug overdose have also increased. What is interesting, though, is for 20 years prior, up until 2019, 1999 to 2019, we had 30% plus increase in deaths by suicide. But 2019 was the first year where that went down a little bit, and it's very early for us to know what the impact of the pandemic might be on deaths by suicide. But thus far, the research suggests that it actually did not go up. And some people suggest that there might be a phenomenon where, during the course of natural disasters, we see communities coming together in a very different way. So it's a little early to say what the true impact is, but we haven't seen a rise in deaths by suicide per se during the early days of the pandemic. Yeah.
That's promising. Sorry, Roger, I was just going to bring up, I know that during one of our conversations, you mentioned that sometimes we might see a lag. So how do you think that's playing a role here?
Yeah, absolutely. I think we definitely anticipate there's going to be a lag on some of the mental wellness concerns that we're seeing in our communities. So just as evidence of some of that, so prior to the pandemic, in any given day, about 20% of the adult U.S. population was experiencing a behavioral health concern. Some of the more recent data shows that that's doubled since the pandemic. And so there's going to be implications of that. As Arpan mentioned, we know that the overdose and other deaths of despair have certainly gone up during the pandemic as well. So I think it's important to note that those incidents of increase of depression and anxiety are not uniformly distributed. They tend to be higher among BIPOC populations and frontline workers. And so it really is not even, we might all be in the same boat, or same storm rather, but not in the same boat. And so the impacts of the pandemic, certainly as it comes to mental wellness, have not really been evenly distributed, but is impacting everyone.
Yeah, thanks for adding that in, Roger. Definitely a critical component. I know also our adolescent population experiencing a lot of increased risk. And if I'm correct, Arpan, I think you're presenting about about adolescent mental health next week. So everyone check that out if that's a particular area of interest. I want to transition this conversation to talk a little bit about how technology can help support people in suicidal crisis. For those of you that have joined our LinkedIn Live sessions previously around behavioral health, we've talked a lot about the spectrum of care and how often our digital tools that we implement are targeting more of the mild to moderate acuity population. And sometimes that's an assumption that people have, that that's really the only area where we can help people. But it's really, across the whole spectrum, there's lots of things that we can do. And so I'm really glad that we're going to be able to talk through this. So, we've got two different projects that we're going to talk about here. One about patients, one about caregivers or employees. And so I'm wondering if the two of you can tee up a little bit about, how technology helps people in suicide crisis, and share a little bit of background on the two projects that we're going to be talking about today.
Yeah, well, one of those tools is a tool to help provide evidence-based care to some of our patients who are most vulnerable, that is, who present in one of our emergency room settings in acute distress, having suicidal thoughts. And the way we think about this is it's similar to a medical stroke in many ways, that we want to make sure that we're delivering the best evidence-based care when somebody presents with a need. And so we want to do that in a really highly reliable way. And so one of the tools that we're going to be utilizing and piloting provides some avenues for that, and that it will provide patients in the emergency rooms with a tablet that will help walk them through some of those processes and questions. It will also help them to have access to some educational modules that have been informed by individuals with lived experience who have been in the emergency rooms with suicidal thoughts, and provide some guidance for the clinical teams as well. And so with that, we hope to demonstrate that we're able to provide that high reliability care. Arpan, anything you want to add about some of the other things we're doing, or some of the other things we're doing?
Yeah, I mean, I would probably just take a step back, because I like the way you frame the question too, Julie, thinking about like the role of technology in mental health, and how people might have traditionally thought about this as maybe for something that could help the worried well. But what we're talking about is, across different segments of the population, there's value. And if the way I think about it, I mean, cell phones are more ubiquitous than running water or stable electricity, right? You have an average of 2,700 touches a day. So just think about the power of that. So there's, if someone is starting to get depressed, they're withdrawn, there's certain patterns in the way they might be using, various platforms on their phone, or however they use technology, that there's a possibility to help them earlier, to identify signs that might not be apparent to them or their loved ones. So I think there's so much power, and we need to just reimagine excellence in the way we think about delivering care, and technology has to be a critical part of that. And I would see this, as you think about the problems we're trying to solve, like there's huge stigma. So, addressing, leveraging technology in a certain way that overcomes that barrier. Most of the care that we provide in mental health is episodic. It's reactive. So you have an opportunity over here. We have an opportunity with technology to kind of overcome some of these things, and then to build on the amazing projects that we're talking about. So we've previously on these discussions talked about expanding the reach in primary care by leveraging tools like computerized cognitive behavioral therapy. But this is a very exciting project because this goes to the other end of the spectrum. Like Roger said, people who are in a suicidal crisis, some of the darkest hours in one's life, some of the and we know that by creating space and distance between someone who has suicidal thoughts and means to harm themselves, you can actually save a life. And we have an opportunity here with technology. So really excited to talk about this.
Great. Yeah, so much to jump into here. Let's start. So, Roger, you kind of outlined a little bit of this project that we're doing in the emergency department. The second portion, what we'll be jumping into after that, is some employee project work that we'll talk about, which harnesses some of the things that ARPAN's talking about. And this work really came out of some of those points that ARPAN was mentioning around stigma, around access. We've been working on zero suicide here at Providence for many years. It's our goal that we're able to implement these robust practices for suicide prevention so that any patient who comes in to see us can get the right care for them, no matter where they're coming in. But the reality is that we know that patients experience crisis when it's not business hours, when they're at home, when they're out and away from where they might be able to see a clinician. And so being able to have support tools at home with them and improving the experience when they're getting care with us. So Jasper is this tool that Roger mentioned, which we're so excited to be testing out in our emergency departments. Roger, thanks for giving us a quick intro about that. I want to talk a little bit first about why were emergency departments the first place that you were thinking about? And is that kind of where you think the bulk of the work is going to be done, or are there other care settings where this tool might apply?
Yeah, great question. So, the EDs are certainly the care site of last resort for many in our communities. And so we really, and EDs are frequently very busy. There can be long wait times. And so really we wanted to optimize and really focus on the EDs and trying to see if we're going to be able to reduce the length of stay, the time that somebody might be spending in an emergency room when they present in a mental health crisis. We want to make that experience as rewarding, if you will, as beneficial as possible. Yes, and to really meet that individual's needs wherever they might be. And so again, using that analogy of another medical kind of emergency, we want to provide that same level of intervention and high reliability care with behavioral health needs. We're starting with the ED, but we think there's a lot of possible use cases. A lot of people, the vast majority of folks, are seen by their primary care provider and their primary care teams for behavioral health concerns. And so we think that there's definitely application and use for a tool like Jasper beyond just the ED, but in other settings as well.
Yeah, and if I may add to that, when you think about people who come into the emergency department in a suicidal crisis, it's a very binary process. So they have an assessment, and either you're going out with a piece of paper to follow up with someone who may or may not have an available appointment for weeks, or you're going to go in and we try to find a bed and you might languish in the EDs for many hours. This is the unfortunate reality in many parts of the country. And so to be able to provide not only that reliable, consistent, evidence-based care every single time and every single encounter, and leveraging technology like Roger alluded to over there with that, but also giving patients something practical to use, some tools that would help them calm themselves in these moments of distress, stories from other people who've walked in their shoes before, that can be very powerful. And the tools that help them while they're in the emergency department can also be used as they move on and they're going home. And, when you think about it, if you're not having a heart attack or a stroke, the one thing that most people have in common in an emergency department is time. So being able to give people an iPad and with this technology to be able to use some of these calming techniques while they're working through the rest of the stuff might actually make make things easier for them.
Yeah, it's such a good point. And Roger, you mentioned this earlier, this idea of bringing in the voice of people with lived experience. I know something that surprised me is that patient experience is often tracked, sometimes excluding people that have mental health diagnoses. And so why is it important that Jasper developed the tool with people who have lived experience? Would one of you talk about maybe, how that can help change the experience for someone who's receiving care?
Yeah, it's so important to include the voice of those folks, those individuals who have been there and have had those experiences and have been in those emergency rooms and can inform the tools to say, okay, this is going to be helpful and this is not going to be helpful. I think that sometimes certainly in the healthcare profession has been can be viewed as somewhat paternalistic at times, and I think that's definitely changing and has changed over the last decade or so. But really, having the voice of the people who will be actually using it and what would be helpful for them is so critical, and not just for us, who the clinical folks making some assumptions from a clinical perspective about what might be useful, but really from the end user perspective, the individual perspective about how might somebody really use this and really make it meaningful.
Yeah. Goes to the basic premise: nothing about you without you.
Mm-hmm.
Yeah, and I think that's such a thing that for me that stood out is that, often when you're receiving care, you feel almost helpless, right? You're just waiting on the next doctor or the next medical assistant or the next nurse. By giving someone a digital tool, they're really in control of the experience they have.
Mm-hmm.
They're able to have a little bit more ownership, providing more data than they might, answering questions that they might not have otherwise been able to share with their care team, being able to access this content, these videos. They're able to drive what they're looking for and what they need in that moment. And so I love that. And it's something that I'm really excited to see how patients respond to. Any last words about Jasper? I know that, given it's Physician Suicide Awareness Day, I don't want to short change some of the other work that we're doing around employee mental health. So I'll give a quick second for last words about Jasper, and then we can transition on.
I think one of the premises here is that for so long, for literally a century, behavioral health has looked like going and seeing somebody individually, whether a psychiatrist or a therapist. And really the technology has changed so much. And if you look at other industries that have changed as a result of technology, and behavioral health, for the most part is not. It's still very, very reliant upon that individual visit. And that nowadays behavioral health doesn't have to look like that. There are technological tools, and to be frank, some deliver better evidence-based care at higher fidelity than individual therapists or psychiatrists do. And so behavioral health doesn't have to look like an individual face-to-face visit anymore. There's still always going to be a place for that, but it doesn't have to be. It can be more convenient and available in 24/7 and in the manner in which an individual would like to receive it.
The only thing I would add about Jasper and this whole the using technology for high reliable care for suicide management is culture change. We've had a historical approach towards having resigned acceptance to deaths by suicide as something that will happen, and we have very limited control or influence over. And I think it's really important that culture change happens, that we know that there are things that can be done and we show how it's done. And I think providing this just-in-time support to providers, beyond just the behavioral health folks, everyone, to be able to provide this is probably going to be an important step in that direction.
Yeah, thanks for talking about both of those. If anyone's interested in learning more about kind of how we envision behavioral health changing, we've published a number of reports on our digital resource center. You can access that at Providence-DIG, the Digital Innovation Group, DIG.org. And we've got a ton of resources that we've published with lots of Roger and Arpan's insights, learnings, and takeaways after a lot of experience with patients and caregivers. So definitely reach out, definitely look out for those if you'd like to see more about how a lot of this scale is possible through technology. But I'm going to transition our conversation over a little bit. I think kind of playing on this theme, Arpan, of what you've talked about is, getting just-in-time care and figuring out how you find the people, who is actually in need at any given moment, and how do you get them the right things? It's such a challenge, especially, at Providence, we've got over 120,000 employees that work with us, and the pandemic has been really challenging for everyone. So Arpan, I'm wondering if you can describe a little bit more about this program that we've launched called My Mental Health Matters for our employees. How did that come about, and what is it doing?
Yeah, well, no, thanks for bringing that up. This is really dear to our hearts. We recognize that, we caring for the mental, emotional well-being of our own caregivers is not just a high priority, it's a precondition if we want to deliver excellence to the patients we serve. So I think this is really important. Now we partnered with the Digital Innovation Group and earlier during the pandemic when people were struggling to address what you just said, like how do you have a way to be responsive when people want help? So we created the stress meter. As we've talked about it before, we've had 30,000 people use it. It's really been a very helpful way for people to navigate and get to places, to get to the kinds of support they need. But we also recognize that most in healthcare, physicians, but nurses and many others don't seek help for themselves. Help-seeking behavior is not something that comes naturally to them. So that's why we also wanted to have an approach that's proactive and kind of outreaches to those who are probably in need, and those who actually need help externally just look like those who don't. It's really hard to say. So how do you strike a conversation? How do you start having, normalize help-seeking behavior? So this program that was started out at University of California, San Diego, which is now taken over by the American Foundation for Suicide Prevention, is what we used as our as the foundation to build this. And it's, three components to it. One is education and destigmatization efforts that normalize help-seeking behavior. So there's a vast campaign, topics around, mental health in the context of work and life, family, relationships, and so on. And, normalizing the conversation by having leaders, people who are trusted in the health system, talk about why their mental health is important and why they're taking care of it. But then also adding with that is just like you think about your annual dental checkup or annual physical that you get, how do you help people with getting access to something that can help them know whether what they're dealing with, is it just normal stress, or is it something that I might need professional help for? Is this serious? So there's an interactive screening program, which is an anonymous platform that's sent out. Takes about 5 to 6 minutes for people to go through. It has intelligence built into the tool that stratifies people in 4 different categories. And in each and every one of these assessments is reviewed by our therapists who are trained on the back end to provide personalized guidance. Roger and I and many others in the team have worked to make sure that the language really is important. How are we communicating? How do we, again, be supportive? And then connect people with appropriate resources when needed. So that's a high level overview of it. Roger, I'm not sure if you want to add more over there.
I would just say that really thinking about this as having proactive tools through education, anti-stigma campaign, information, and then reactive tools so that when somebody does reach out for help, we have the right resource for them in the way that they want to receive it. And services kind of along that continuum of proactive to reactive is really critical.
Thanks. Now, Roger, Arpan mentioned something about, this tool being anonymous. And I imagine that with employees, it can feel pretty scary to talk about these topics or concerns you might have with with the group that employs you. How are you addressing privacy, and how does technology that's such a common concern what are you doing to think about that?
Yeah, great question. And particularly when people are concerned about implications on their medical license or their nursing license and things as well. And so that's really one of the reasons that we have partnered with the American Foundation for Suicide Prevention. So this confidential and anonymous mental health screening is housed on the American Foundation for Suicide Prevention's platform. So it's outside of Providence's firewalls. We don't have any access to it at all except for aggregated data. We don't even necessarily know what region of or what state one of our employees might be from when they complete the mental health checkup. And we really emphasize that. There are some challenges with that, particularly for folks that might be at higher risk that we really want to make sure we're reaching and getting resources to. But the trade-off is having that be confidential and anonymous and not having there be barriers to our employees from completing the mental health checkup, feeling more comfortable with it.
Thanks. So I know that we're coming up at the end of our half hour here, and I want to just leave a couple minutes for closing words. Any last pieces of advice, things that you want to talk about, especially given that it's Suicide Prevention Month, it's Physician Suicide Awareness Day? Any last takeaways for the audience?
Yeah, I would say that these efforts, they traditionally in the past in employer groups, healthcare or otherwise, they have been sort of limited campaigns, if you will. They've been and this work really needs to be sustained. This really needs to be part of the new normal about how we engage with our employee groups and some of the services that we provide. And I would say that extends beyond healthcare. We're seeing a lot of this happening in other corporations as well, and other places of work. So this work really needs to be sustained over time. It can't just be a one-time effort and then call it good. We have to really commit as organizations and as leaders to this work moving forward.
I would say that suicide. It's important to recognize that suicide prevention is not just a behavioral health problem. It's not just a medical problem. It's a societal problem. And I urge all our listeners to show up for each other. Make sure that you're having authentic conversations. Check in with somebody you know, you love, you work with, you care for, or care with if you're a caregiver in the health system, and ask them, how are you doing, really? And strike a conversation. Normalize things. It's okay not to be okay, and be able to provide support to each other, and take care of yourselves. Take care of yourselves and get help when you need to.
Great points from both of you. Thanks so much. I know I'm grateful to work for an organization that really lives by its mission to support the community that we serve, and is doing so much to help our caregivers and our employees, our patients, our community members in their time of need. So thank you, Arpan and Roger, for joining us. Thank you to all of you for listening to us today and sharing the questions that you sent in that we were tracking. To learn more about the work that we're doing within the Digital Innovation Group and the work that we're partnering with our clinical, operational, and population health teams, you can access that at providence.org. Or to reach our digital specific resources, you can reach us at providence-dig.org. And make sure to follow us on social media. We've got LinkedIn, Facebook, Instagram, and Providence, Twitter, all under Providence. So lots of great content coming out every day. So thanks so much for joining us. I hope everyone has a good weekend and is able to take care.
Thank you.
Thank you.